really these are life and death critical situations. So having, an expert be able to guide us through things and answer the little questions or details that we just don't see that equipment very often. Don't know if people know, but how you drain a pericardial tamponade is sticking a needle at the bottom of someone's heart. So that's not something you want to, take lightly or guess.
Hey, I'm Jim Wiedrick. Every day, along with others, I'm transforming healthcare in the Southeastern BC zone. And I currently work as an emerge physician at the Kootenay Lake Hospital in Nelson. So we all recognize that health and healthcare is at the center of it all. And so my big idea is, how can we optimize things? What can we get and make in the system so it can be its best? With that, I have aimed to draw together a wide panel of people. I want to hear what they're seeing, what they're doing, what their big ideas are for the future. I'm really pleased today that someone I've known in the workspace for 10 years is willing to join me today and talk about her takes. And that's Lisa Keech. She's the patient care coordinator for the High Acuity Response Team out of the Kootenay Boundary. And hey, when you break down that acronym, High Acuity Response Team gets called HART, H-A-R-T. And here's Lisa to bring her heart and passion to this discussion. And thanks for joining me today, Lisa.
Thank you, Jim. I appreciate it.
Yeah. So, Lisa, is it okay if you just kind of give the folks a quick taste of what it means to be on a high acuity response team? What does that team do, and what's their role in the big sort of network of our healthcare system?
That's a great question. And I think a lot of people don't know what we do. Not that that's why we do what we do, of course, but I think it is important to know that our health authority has chosen this resource. So basically, Interior Health has started this HART program in 2010, basically to transport patients around our health authority, and I'll talk about geographics in a sec, that require greater than BLS care. So BLS meaning basic life support care that's typically provided by our 911 paramedics. This is an interfacility model. It's not what paramedics do, and bless them for what they do, because that's why I'm a nurse, not a paramedic. So quite a long time ago now, it was identified that paramedicine 911 calls were becoming overwhelming for the workforce and system that was set up to respond to that, because not only did patients need 911 care, they also then needed to move between hospitals for various things, whether some things are not available in all of our small local hospitals, which everybody on this podcast, I'm sure, is going to be well aware. We can talk about those things later too. We might have some ideas between Jim and I, who have been around the block once or twice. And that resulted in those patients waiting, because if you have limited resources, especially back in 2010 when we did with paramedics, sometimes patients in hospital would wait because the priority would be the 911 calls. And of course, as we know, many of our loved ones have had to experience waits in hospitals to get to our bigger centers. In our area, it's typically waiting to go to Kelowna. So our team was born out of that need to provide critical care to these patients requiring interfacility transport. So it started off with our base. Our trail base was the first base in Interior Health, which also I think is a testament to work done by our Interior Health leadership, because it was a little town that got something first, not just all the big cities. So I do realize that healthcare is a challenge, but we do have to celebrate some of the wins that happen sometimes. So our base was the first. It then followed along with Royal Inland up in Kamloops, and then Cranbrook, our fellows to the other side of the Kootenay, and then Penticton, and then just this past year, there was a base actually opened up in Kelowna. So each of these bases has their own...
So that's...
Sorry.
The Kelowna is meant to be complementary to all the other sites, or does Kelowna have a specific need itself?
Yeah, actually, their needs were initially prospected to be similar to ours, but have actually changed. Maybe I'll back up just a little bit. So our geographical area for our Kootenay Boundary HART team is basically a circle from Grand Forks around through us in the Kootenay boundary right where we are, Trail Nelson, up to Nakusp and Caslow and everything in between. And then we share Creston with the Cranbrook team. So every one of the HART bases has a bit of a geographical circle, so to speak. And then the Kelowna team was meant to bring on that like Shuswap kind of area around there, Vernon. So of course, that's quite a large population. But what they've actually been able to do, again, a big picture win, is they are meeting a lot of the critical care paramedic teams, which are run by BC Ambulance, at the airport in Kelowna, which is freeing up that aircraft and that critical care resource to get back in the air so much faster. Like we're talking hours faster. I'm not sure everybody realizes how long it takes for a patient to get from an airport to a hospital or vice versa. It means, landing the plane, doing the safety things, offloading a patient who's quite ill, often onto the tarmac with all of their lines and tubes and machines. And we're talking life support machines. So it's not something you want to just, mess around with, as you know, and then load them into another ambulance, get all your gear sorted and everything has to be safe, drive through downtown Kelowna traffic, because of course you only ever have to go at rush hour in Kelowna, it seems. So that get from the airport to Kelowna Hospital can take upwards of a half an hour itself. And then, of course, unload into the Kelowna General Hospital, offload into whether it's emergency, ICU, wherever they're going, give report, clean up your gear, and then reverse back. So that can add up to hours for the very precious critical care that we do have in our province. So that's actually been a win that I don't know that was anticipated, but that's made a difference for us in the Kootenays because, Jim, I know in Nelson you've had more than 2 patients needing to go out at a time. If it's going to be a plane appropriate patient, that wait is hours and hours and hours. So what we've been seeing here is that a plane could come here in the morning, pick up a patient at, 10, 11, whatever time, randomly pick one, and be landing in Kelowna about a half an hour or so later, depending on the wind, and be back in the air 20 minutes later instead of 3 or 4 hours. So we've actually seen planes pick up a patient and return to trail, which I can speak to because I've seen it, in under 2 hours.
Yeah, that's progress.
You're lucky to see a plane twice within your daylight hours of the Kootenays. Now, especially now that it's getting dark, which is a huge difference.
Well, that's definitely something that, like if you live in the lower mainland, Vancouver, or if you've just learned about emergency medicine from American TV, you don't realize what we have as, if you will, impediments to being able to get people to higher levels of care in a beautiful but more remote or isolated part of the province like we have. And, sometimes the universe brings good things and anecdotes, and that was kind of the phenomena this past weekend when I was on shift, and just like you mentioned, 2 sick people at a time, and they figured out how to get one person who had a phenomena called cardiac tamponade, where their heart just isn't able to pump because it's got so much fluid around it in its surrounding sac, and she needed to go out by plane. But then I was working on another patient in conjunction with some other doctors and a member of the High Acuity Response Team, while we were then needing to transport them by ground to Kelowna. And so, it was an example of where, because they could come to our site, be a support, and then get people mobilized, there is benefit in that, but it still takes hours. And so we're doing a procedure remotely to save someone's life in an emerge that we don't have a ton of familiarity with, but we're getting guidance over the phone, and then people are having to get transported off to Kelowna, and it takes a long time. There's 2 mountain passes and 5 hours of driving or some there amount, eh?
It's a lot. It's a lot of stress on patients, as well as our little systems, I'll call our little hospitals, like all the little systems.
So you were able to paint a bit of an optimistic picture, but what would you put as the emphasis on, like in the system right now, what's working really well Because you can probably imagine I'm going to follow up with, well, what isn't working so well? So let's start with the good stuff. What would you say are the highlights in the way our system is set up at the moment and that's working well?
Yeah, I think it's a great question. And I think we always do need to address the things that are working well. I think everybody's well aware that large systems don't always work well. So we do have to look at positive things. And I believe in that because otherwise it's too easy to just fall into the negative of what isn't working well. I really do think that our system is looking at how to make things better. I know that a long time ago, the regionalization of things and the spreading out of resources was a decision made by people, well, probably some who may not even be with us on this planet anymore. And that may have been the right thing for healthcare at the time. I am not going to profess to be an expert at what decisions were then, but now I do see some decisions being made like this Kelowna team for transport for us, which has been able to offload some of those issues. Like you were able to get those 2 patients out. That wouldn't have probably been a thing otherwise. And you'd have been left sitting with those in a very small emerge that does not have that capacity. Now, with that being said, everybody is phenomenal in these sites. It's just a matter of experience and numbers. I come into Nelson and, there's 1, sometimes 2 doctors, 3, maybe 4 nurses, maybe some other help you can wrangle from the building. So, what is that? 5, 6 people. And then our team of, 2 plus 2 paramedics. So 4 more, which, maybe makes you a max of 10. I walk that same person into the trauma bay, into the Kelowna emergency department or ICU. There's easily 20 people around to take over and do those jobs. So it's phenomenal what we do. So that Kelowna team has added some pressure off of that for our rural sites. Our health authority has put a lot of investment into education for our rural and remote staff. Prior to about 5 years ago, the pandemic thing kind of threw a bit of a wrench into stuff. There were certain educational opportunities like PALS, which is Pediatric Advanced Life Support, which were not mandatory for our emergency room nurses, which is crazy. I'll use that word for people that are expected to respond to an extremely ill child. Those opportunities have been well offered. There's a new network on education, and the priority of it, and I've seen it, is getting rural and remote nurses into these educational seats and opportunities. So I think that's great because lack of feeling support or knowledge about things we just don't, thankfully, see a lot of, I guess, is a huge stressor for rural and remote staff. And any extra education or things like that are a huge benefit to our patients and our recruitment and retention of staff.
Because the cases are so infrequent, but when they happen, they're critical and things, all the details matter, and you have to be expected to perform at a quality level. Yeah.
And then you alluded to something else that has happened, which I think is fantastic in your story about that pericardial tamponade, and I wish I was there. I do like that stuff. I have transported stuff.
Yeah.
It's a little bit of good stuff.
Was TV. It was TV in real life.
It is kind of the highlights of why we do these things. But there are virtual options being made available to us in smaller sites that are invaluable. I'm sure you felt much more supported knowing you've got, the big head in the background or the voice guiding us through things that we just don't see very often. And really, these are life and death critical situations. So having, an expert be able to guide us through things and answer the little questions or details that we just don't see that equipment very often. And as I don't know if people know, but how you drain a pericardial tamponade, it's sticking a needle at the bottom of someone's heart. So that's not something you want to, take lightly or guess. Much more reassuring to have someone be able to support that. And I think that's really made a big difference. There are adult, pediatric, and obstetrical versions of online support for those. So I think that's also a huge win in healthcare. So,
well, whether it's having a point of care ultrasound machine, or like you said, a virtual hookup to a specialist, might be at a different geographical location, but can still either watch or guide, give, that a quick little kind of high expertise. It all matters. And, I can remember in the 90s, working as a medical student on the wards and carrying around this little red binder, and I was feverishly writing things down because I was going to remember them. I don't need anything like a little red binder anymore. The Internet of Things is amazing, and all the different ways you can access folks through telecommunications in the last 30 years. It's kind of a real marvel when you sit down and actually analyze it. Things that we used to rely on textbooks for, now they're just antiquated, and yet we have a much better way of doing it. And then we've also had simulations. It's a little bit, I think, tangential to the exact work that you do, but I know that you've been an instructor for courses that I've taken part in, and we're often using dummies or mannequins or high fidelity simulators to just help people get training in those kind of things.
Yeah, and it's made a big difference. And I have a big passion for those things because I know it makes a difference. And it may not be perfect, but any step we can take forward to provide education, as well as my favorite part of it is the team bonding. Groups from our small little hospitals get together, and it is strength in numbers out here. So, a lot of the challenges in healthcare are based on communication, conflict, that kind of thing. So the more we get to know each other and our resources and limitations, I think is really important in being able to understand and help each other when we need to. So I like to think that my colleagues know me well and know they could pick up a phone anytime and call me if they needed help. And I would be more than happy to answer that and help my colleagues through a difficult situations. It's important.
Well, yeah, and a compliment going your way is that when you bring a certain energy all the time to your workspace and whatnot, and people see that you're enthusiastic and you're engaged and you care, then people are more likely to be willing to reach out. And, I think of you as somebody like, hey, I could ask Lisa, that'd be okay. And it's a good reminder to me or any of the rest of us to be that person too, because sometimes we don't all have quite the same personality. But yeah, kudos to that. So tell me something, then flip the dial and go, well, what do we need to improve? What do you immediately sort of see and say, well, that's not where it needs to be, and maybe here's a way we could upgrade it. What do you got on that list?
Yeah, fair. I don't always look at gaps in our system as a negative. I know that it's easy to do. I can complain like the best of us when I don't get what I think we need. I do have a very strong built-in sense of fairness and justice. And that meter sometimes, boy, oh boy, because that's not fair. And I try to not live in that because of the reasons I'll talk about. Some of the things our system has really needs to look at is really looking back at rural and remote areas or ones with geographical issues. We can't all live in a big city where resources are all put. And that would be unsustainable for anything regardless. So I really think that needs to start coming back. And I do see small steps of it. But the problem with it, so this negative part of it, is I really do believe our system, I'm just going to go with interior health as the system I'm going to talk about, is vast. It takes forever, seemingly, to do anything small. If you and I have an idea, Jim, it probably would be the best idea on the planet because you and I know a lot of stuff and have the experience to back it up. And to say we really need this, you have to go through multiple levels of people, and there's multiple meetings and committees. And then what else happens in the system is people change their jobs and you start all over again. And then even after it gets maybe approved by Interior Health, it may have to go to the ministry. And then that whole process happens again. So there's things that I've seen, and I'm sure you have too, that should be a slam dunk implementation. And it's years later, and we still sit there and think, what on earth? This is just a small piece, and it's taken so long. So I really do think that our system needs to somehow get rid of those layers or make those layers more efficient or something. It's a real sense of frustration for the people that know how to improve our healthcare for our patients. I deeply love all of our patients in our community. And what frustrates me, and I know many others, is that I know that sometimes these little things, and sometimes they're big things, need to happen. And sometimes I just know it's not going to. So I really think our system somehow needs to do that. I don't have great answers as to why or how that could happen, but I really think somebody at the top needs to look down. By the top, I'm meaning like our premier ministers of health. They need to start looking at why are there 15 layers between us, the front line, and anybody that can actually sign the document that says, yes, Jim, you can have a portable CPR machine, which took you guys way too long to get in a small hospital, as one tiny example of a massive change for our area.
There's really a lack of what I would call nimbleness, and we've somehow seemed to create a bureaucratic thickness that isn't easy to navigate. And then you spoke to the bit about institutional memory, and folks who are doing frontline care often have to also engage in some of that bureaucracy to help make decisions. But then, like, even in my 5 years when I was the local chief of staff, first year or so was me learning and figuring out where I could access things. And then it took another year to get kind of more skilled in some of the ways of the bureaucratic world. And then I had 3 years of being fairly effective, but eventually I want to move on to other things, and then someone replaces me and it takes them 1 year plus 1 year. And you lose some of that institutional memory if you're not really practicing how to navigate these pieces. So I think you're right, there's turnover and there's kind of a churn that doesn't work. So I wonder, can we just blow it up and get more local decision making? Can we just like flatten the org structure of how healthcare runs? We do seem to have a little bit of a monolithic thing that all eventually leads to Victoria.
Yeah. It's interesting, as I was at some leadership things lately. I am a frontline leader, which
patient care coordinator. You bet.
Which is a very interesting thing because there's a long way between me and decision makers. But anyways, I was at this thing and I was looking at organizational charts, as I once in a while do if I really just want to sit there and zen on something. I was trying to figure out, I was having a roadblock and I was trying to figure out where I could break through that roadblock. And like you kind of alluded to, you have to kind of be crafty on where you go and how you go because of some of those real life things. I know that this person has been around forever and knew all the history, so I wanted to be able to find that person. But what blew me away is the organizational chart, just in interior health that is part of the chain that my program belongs to, has something like 21 layers.
Ooh.
And I was really shocked. I had not looked at that for a while. And what it really did to me was I went through all the stages of anger at that point. I was angry, I was frustrated, and then I was disheartened. And then all of those things happened. And I just thought, wow, this is so much to try to get through. And I just don't even understand what the purpose of every layer is. So that doesn't help the yous and me's down here trying to elicit a change and be the leader that we're stepping up to be in our organizations. When you don't really know how to do it, it takes you 2 years to try to figure that out. And that's a long and a short time, depending on how you look at it. But when we see issues in our rural area, 2 years is a long time, and adds to frustration and burnout. And then people say, you know what, this politics stuff, I want nothing to do with, because it's just so draining. The personality of people that tend to be in emergency.
Well, I'm gonna jump in and give a quick example of something that I've heard argued, and it just really made me shake my head. We've been advancing a case locally, and both the Kootenay Boundary Regional Hospital, so that's Trail, and Kootenay Lake Hospital, that's Nelson, but we both need new CT scanners. And for a couple of years now, I've heard, well, it'll be next year. And so I think I think there's a credible case to be made that they really are going to proceed with it in 2025, but I heard about 6 to 12 months ago, well, we can't proceed with that because we don't have a project manager who's free to do something, oversight it. And I was like, we could have fully fundraised from the community, and if you just let me work on this with, a handful of people that I could put together with expertise, we could have done it locally, made it happen. It's not inventing a spaceship. It's using technology that's been around for decades, and upgrading it. It's like the same as replacing your home entertainment system at home. I mean, me and 2 or 3 qualified techs could work it out, but this excuse that got made was, well, we need to have a project manager free. Not feeling it.
Yeah, I know. And then what leads to that is then there's a whole new level in our system of this project manager people and all of the support that they need. And then somebody has to prioritize their work. So yeah, it's almost an impossible circle. So yeah, that is really one big challenge that I see. Another one that I see is I don't believe, maybe due to all those levels, that our system is working to its best capacity, just due to those roadblocks. I'm not seeing advances in our practice ability. I'm not seeing advances in, for example, registered nurses have more capacity to do other things, and it's not being pushed forward. For example, and there's a low-level one, suturing. It is within the registered nurse scope of practice. It's not been promoted, at least that I've heard of in our health authority. I'm not sure about others. There's pluses and minuses to adding on workload to things, but also in an era of physician shortage, if that half hour that it took you frees you up to go see however many people you can see in that time, even if it's one sick person or 10 fast-tracky, not so sick people, that's a huge difference. So I just don't see that being promoted well. And, that frees up your time. It gives people, more job satisfaction because now there's something, more meaningful I could do. Our LPNs are another, licensed practical nurses are another group that are not being utilized near to their potential. And it's just not, sure, my cat's going to come and say hello now.
Oh, hi there.
This is Franklin.
Mr. Whiskas.
She's 14.
Oh, hi.
And
Yes.
wants to be with me. We're just not advancing our system to catch up with what we could be doing. And that is a bit frustrating as well, because you as an emergency room physician could be far better utilized than sit there doing basic sewing in a room for a long, long time.
Definitely understand where you're going with that. The bit about silos and how people get compartmentalized and, well, that's my job or something like that. And then it just has the domino effect or the cascade effect. As soon as I'm tied up for 30 to 60 minutes doing X, that means other layers of things don't get worked on or don't get attended to.
Yeah, and what the public sees is, and I've seen it in comments, and you probably have as well, well, everybody's just sitting there and nothing's happening for me, the patient. Yeah, because the only person that can sign off what the next plan is stuck in a room doing, something that could be offloaded to someone else. And I just think our efficiency gaps are not really being looked at. Quite a few years ago, there was a whole lean system that was kind of brought in, which was supposed to look at inefficiencies in healthcare and utilizing the best person for that job for that time. And I think it had a good start, and then I don't really hear much about it anymore.
Yeah, I would actually ask, where did it go? I don't know.
Yeah.
I'm almost ashamed to say I don't know where it
know.
went, but it's not being talked about.
I don't know that I want to ask, because then it's assigning me to a whole chasing down. But what I did notice that it did was it looked at a lot of bigger systems first, which maybe is right, maybe it isn't. But what I really wanted out of it was to come into your emergency room, Jim, and follow everyone around for a few days, the ones that are touching the patients, like right from when the patient walks through that door or is brought in by ambulance to the time they're either discharged or admitted, whatever, and all of the things that happen in there. Because I think that's where our wins are, is when we look at the biggest initial impacts to patients and staff. Because really, I don't love playing hierarchy, but the most important things in our system is the patients and the ones directly looking after them, and all support should be surrounded to that bubble of people.
I like it. Yes, right on. Lisa, we could talk all day. I think you and I, we have that potential, but I am going to say, hey, this was fun. I liked it. I'm really grateful you took the time to join me. I hope that people have taken 1, 2, or 3 pearls of wisdom from it, and that they might even understand what's going on in our lives and our transport systems, and that they'd be happy to engage and just continue to work with all of us to try and optimize what we got. Thank you.